Hello, everyone coming in. If you are able to turn on your camera, that would be wonderful. But we understand if you can't. Thank you so much for joining us this evening. Welcome to the first session of the Reimagine series, The Pursuit of Justice, From Inequity to Integrity. My name is Andrew Engel. I lead virtual programming at Reimagine. I live in New York City, located in Lenape-Hoking, which is the indigenous name of the unceded land of the Lenape peoples. During the colonial era and in the early federal period, many Native folks were removed west and north, and some remained among the continuing historical tribal communities in this region. I acknowledge the indigenous territory where I am to remind myself that more steps are needed to undo generations of damage caused by colonialism and white supremacy. Please let us know where all of you are at. Please put that in the chat. My pronouns are he, him. For those of you who need a visual description, I am a white cisgender male with glasses, salt and pepper hair that's getting grayer by the day. I'm wearing a blue striped shirt and I've got a bright orange background behind me. Today, my colleague Lily Liu, who regularly hosts programs as part of Reimagine's community of collaborators, is providing assistance with this gathering. Thank you, Lily. Reimagine is a nonprofit organization catalyzing a uniquely powerful community. People of different backgrounds, ages, races, and faiths, people of no faith, all coming together to heal ourselves, our communities, and the world. We support each other in facing adversity, loss, and mortality, and to transform life's biggest challenges into meaningful action and growth. Reimagine resources, support groups, and events like this one today are free and accessible to the public. This is made possible by the support and generosity of participants like you. So for those who already made a tax-deductible donation when you registered for today's program, thank you. Your gift will immediately support Reimagine's mission to help people of all walks of life to transform the hardest parts into purpose and action. So we've been exploring a wide variety of topics, looking at different aspects of loss, grief, and struggle through the lens of what's known as post-traumatic growth. Previous series have focused on aging, money, career, climate change, addiction, you name it. We at Reimagine believe that building a more just and equitable society is an act of service and an act of love. In our own communities across the U.S., we do what we can to repair what's broken. We take steps to end violence, to reduce poverty, to alleviate food insecurity, to make sure everyone has a place to live, and to ensure that everyone, regardless of age, ability, race, religion, sexual orientation, gender identity, or income level, gets good care. Injustice is a source of pain and grief. I want to suggest that working towards justice and facing personal or collective struggle with inequity can also be a source of strength. At Reimagine, we've been leaning into post-traumatic growth. It's evidence-based psychology suggesting that adversity can ultimately lead to transformation and knowledge. Since we have two chaplains present on our panel, and there are probably more in this community that I haven't even acknowledged yet, I want to acknowledge that this concept of grief to growth or post-traumatic growth also has spiritual roots. For Jews and Christians, we can see how individuals can transform when they are wounded. Jacob wrestled with the angel, experienced a trauma, it was a hip injury, and then became a more humble person. And also, if we have Muslim community in the house, I want to wish everyone a Ramadan Kareem. Another example of post-traumatic growth and spiritual traditions that I really appreciate is one from Thich Nhat Hanh, famous Buddhist monk and peacemaker. He popularized the expression, no mud, no lotus. So struggle is what makes things bloom. The question I've been thinking about is, when inequities create grief and a sense of mistrust, can the restoration of justice aid personal and collective growth? Can taking steps towards making things right reduce our own despair, improve our well-being, and help us to appreciate the humanity that connects us all? So please, if you haven't yet, register for the next 2 sessions of the Pursuit of Justice, this series. And this is what we have coming ahead. Next Wednesday, we've got a workshop, and the 3rd session, another team of wonderful palliative care folks are joining us. A few Zoom tips for all of you. For those who wish, click on the CC icon to get a live transcript of what's being said. You can save the chat, and please use that chat by clicking on the 3 dots within the chat box. And feel free to send me or Lily a note if you're having any trouble. We'll try to help. We are recording this program, if you haven't noticed. So everyone who has registered for this workshop will get a follow-up email with a link to the video. And now I can stop my share, and I can really see all of you. Welcome. All 3 of our guests tonight work at hospitals. So when asking the question, what does justice look like? We are encouraging Chaplain Clark, Pastor Corey, and Dr. Zitter to answer that question in their professional capacities. What does justice-centered healthcare look like for patients and for staff? How do you cultivate justice on an interpersonal level, on a systemic level? How do we make patients feel seen as whole persons? How do we make sure that staff feel seen, especially now in this post-pandemic period when compassion fatigue and burnout is at a high? I guarantee we will get some wise words from our 3 speakers. And I've talked long enough, so now I'm going to do my introductions. First, we have Chaplain Betty Clark. She holds a Master of Divinity from Graduate Theological Union in Berkeley. She has worked as a hospice chaplain for 16 years and as a palliative care chaplain at Alameda Health System for 12 years. Chaplain Clark is the founder of the Church Without Walls in Oakland, a congregation offering spiritual care, counseling, and life cycle events. She is the founder of the East Bay Community End-of-Life Coalition and currently the president of the board of the Arc of the East Bay, which offers life skills education, job training, and placement to adults with intellectual and developmental disabilities. Welcome, Betty.
Thank you.
Betty's colleague, Dr. Jessica Zitter, has been working with her for over a decade at Highland Hospital in Oakland, California. Dr. Zitter practices both critical care and palliative care. She is also a documentary filmmaker and author. Her book, Extreme Measures: Finding a Better Path to the End of Life, describes her evolution from being a physician focused on medical protocols to one focused on the human being. And I can't believe they don't teach this stuff in medical school. Dr. Zitter was part of the team that created the Oscar and Emmy-nominated Netflix documentary Extremis, which featured her work in the ICU. Her follow-up film, Caregiver, A Love Story, examines the national crisis of the family caregiver burden. And we're going to get a sneak peek of Real Medicine's newest film in progress, The Chaplain of Oakland, and it stars you-know-who. And finally, I'm pleased to introduce to you Corey Kennard, if you don't know him already. He will guide the discussion with Dr. Zitter and Chaplain Betty. Pastor Corey is a leading voice in the transformation of healthcare, and we are so fortunate to have him as chair of the Reimagine Board. He and Dr. Zitter initiated conversations about healthcare disparities at the first Reimagine festivals back in 2018 and 2019. As a chaplain, educator, and administrator, Corey has a decade of experience in palliative care and hospice. He serves as pastor of Amplify Christian Church in Detroit. Now, Corey, before I pass the baton to you to lead the discussion with Chaplain Betty and Dr. Jessica, and before we see the trailer, I think it's important to share with all of you at least one definition of justice to get ourselves grounded in this discussion. So our colleague Mazen Jamal has suggested that justice is, and Betty, you will put this in the chat? Not Betty, sorry. Lily, you will put this in the chat. Thank you. Justice is a state of integrity and wholeness achieved through healing and transformation. When justice is present, we can trust that our safety and well-being are valued in a community or society. Corey, what parts of that definition resonate with you? Is there anything you want to add to that?
Well, first of all, welcome everyone. I appreciate everyone being here tonight. It is so important that you are here, and you're here on purpose. To answer your question, Andy, and I really appreciate your energy tonight. It's absolutely awesome. I want to say that the entire definition resonates with me. There's no part of it that really you can just leave out and say it's okay. Is there more to add to it? I'm sure that we all have our own definitions and our own ways of explaining justice. But at the core, when you talk about a state of integrity and wholeness, this is what people are seeking. And we're going to talk a little bit more about that tonight because it's important for us to understand how important justice is in healthcare. So if you don't want to talk about justice tonight, you might as well tune in to something else. But tonight, we're going to talk about justice and the detriments of injustice in society, and especially in healthcare specifically. And that's going to be our focus tonight. So we're not going to take it all over the map. We're going to really hone in on how people are treated by our healthcare systems. This is going to be very important for us to discuss tonight. And so I'm excited to have two of my dearest friends with us tonight, Jessica and Betty. And if you all don't know, Jessica Zitter is the reason why I'm sitting in the seat that I'm sitting in Reimagine today, because she was the one that introduced me to this great organization. And I had the pleasure of sharing the platform with her and talking about subject matter that's very similar to this at another date and time in the past. But we're here now, and we're continuing to grow and continuing to move forward. And Betty is just such a dear person to me. And so I thank the both of you for being literally together on this broadcast tonight. And so with that being said, Jessica, and I'll just, for the sake of the group, she is an absolutely awesome individual. Andy did a great job of introducing her, as well as Chaplain Betty. But I want to get into this film because this film is why we are here tonight. It is a great part of what we want to talk about. And so, Jessica, or to others, Dr. Zitter, how in the world did this film hit you? What were the origins of this film? We're excited to know, before we even see the trailer, we are excited to know, how did you get this concept, and what really moved you to want to produce a film such as this?
Well, first of all, Corey, so good to see you. And I love to tell the group how I first met Corey, but it's a great story, very inspiring. One day, when we have more time, very inspiring person. This woman and I have worked together for how many years now? 13?
Just about 12, going on 13, yeah.
And, I honestly didn't know what I didn't know. And I guess you helped me see what I didn't know. And I still don't know a lot. But, it's not typical for a doctor to be mentored by a chaplain. It's not a typical thing. You don't see it very often, and I wasn't really looking for a mentor in the chaplaincy world. I didn't really think I thought we were doing different things. Betty was taking care of the spirit. but I was taking care of the body. And I didn't understand how much I needed to be thinking about the body, the spirit, and how critically important it was. And I started to watch Betty in the times that I was in the room with her, which wasn't very often, because in the beginning, I didn't tend to go around with her. We were on the same team, but we just did our own work. And when I would see her in the room, it was sort of magical. And it was impossible to ignore. And so I started being more and more interested in paying more and more attention and interviewing Betty. I would stick
a camera in my face.
Stick a camera in my iPhone or an audio, and could you say that again? And it just became, I just realized what I had been missing. And then the issue of race, racial injustice, racism in healthcare, that was something that came, I guess, along with that, but it became impossible to ignore. Betty is of the community that we care for, and it shares a lived experience that I don't. And just in starting to trust Betty and starting to learn from Betty, it was impossible not to see the things that Betty saw every single day. And I started to see too, but it took a long time. So.
Wow, it's absolutely awesome. And Betty, we're going to hear more from you in a moment, but I don't want us to delay, because you're going to see the star of this film right now being displayed in this trailer. And so with that, Jessica, we're going to go ahead and take it to the trailer.
All right, hold on one second. Here we go.
I was born a daughter of an indentured slave. As a little girl, I was poisoned with arsenic from the well water. There was a time in my life when I couldn't walk. And when I finally was able to walk, I said, I'll never sit down. I'll never stop. When I come to work, I bring all that with me. I see people suffering because of racism and injustice. We still sing and still smile. How you doing today?
I'm just a little bit cold.
Are you cold?
How can you come into a patient's room talking about them but not to them?
Thank you so much.
How does that make the patient feel?
I love you.
What? Betty and I have worked together for more than, 11 years now. One of the things I've learned from Chaplain Betty Clark is you never know the full story.
When I get hospitalized, they try to say opioid dependency or something.
Right, and that you're seeking drugs.
And that I'm seeking drugs. It makes me feel
right.
the drug addict.
People have biases. I don't think doctors intentionally want to do those things, but it is reflected in the way that we give care.
People do not understand.
She doesn't trust us at all.
It's another system that is not working in our favor.
Betty, what happened? How far can you walk, you think, before feeling shortness of breath?
Now, wait a minute. I need to know, why are you in that position?
Because every once in a while, you need to be in the place of those you care for.
Oh, I made an outbreak.
Father in heaven, we thank you so much.
I try to help people to understand how to live in whatever section of the journey you're on. Walk with me, Lord.
I got this, Lord. You got this. I got this. You do your part. I do.
There's a saying that I have, that people don't care how much you know until they know how much you care. I want Jesus to walk with me. How you doing?
Wow. And I'm sure that everybody that just witnessed what I witnessed as well should be saying the same thing. And so after seeing that, I just have to ask this question. As the film is, I understand, is still in production, right? It's still in production. So that's just a snippet of what we have to look forward to. But answer this question. Why should we see this film?
You asking me?
Chaplain Betty, let's go. Why should we see this film?
I tell my community they need to see this film because we need to have a voice in our care. We need to know that there is injustice and that you can speak up and you can tell people what you need. I find people all the time in the hospital crying, feeling like they're being guinea pigs. You know, someone's experimenting on me, or they won't give me pain medication, or the doctors will say, well, they won't talk to us. And I find out that it's something in their childhood that they need to talk about. And when they get that out, then they're able to speak. So we really need to be able to tell our stories and not hold them in. And people need to hear. They need to listen.
So this film will encourage people to take back their voice and speak up and really stand up for themselves when it comes to their own health care that they are receiving.
Yeah, I believe that people sometimes feel like that's the way it is. That's the way it is for everybody, you know? Everyone's treated that way, and that's not true. Everyone's not talked to the same way. They're not talked about the same way. So we need to know the difference.
And can I add something?
Yes, please.
Betty's talking about what do people in the African-American community need to know. And it's funny how we kind of approach it we have sort of two different audiences in mind. I also want people in the African-American community to resonate, to find this empowering. And I'm really thinking about my community of doctors and nurses and all of the people working in hospitals who are, for the most part, very well-meaning people who come to work and don't know what we don't know, don't feel what we don't feel. And that I think that this film is going to help people. The way Betty over the years has shown me something new that I didn't know. I hope that even if this is a short experience of 60 to 90 minutes, that people can see something that they didn't know and feel differently.
And people do change in the way they treat people when they know, when they hear, when they understand. And can I just share a short story?
Please do.
So there was a young boy who had been shot playing basketball in a park. And because of that, he became a paraplegic at about 12 years old. When he was around 14, he was waiting in his wheelchair for a bus with a group of other kids. They were going to a birthday party. The police came along, dragged him out of his chair, left his chair, injured him, took him to jail with they didn't charge him with anything. Then they released him. He ended up back in the hospital at Highland with no wheelchair, only being cared for by a grandmother. His grandfather had died the same day he got shot. And so I'm in the room listening to his story. He's telling me everything. And as I come out to the desk in the old hospital, this woman who's in charge of giving people wheelchairs and equipment, and she started, he's not getting another wheelchair, she says. We gave him one wheelchair. He's not getting another one. And I said, do you know his story? And she said, no, Betty, what's his story? So I told her. And by the time I finished, she said, he's getting a wheelchair. So it makes a difference when people know the story.
You know, I feel like society teaches us that we are not supposed to connect if we're not, if we don't look the same as somebody else, if we don't love the same as someone else, then there are these walls that are put up. And in the trailer, there was the word bias that was mentioned. And we understand that this film is not just about the mistreatment of African Americans in the healthcare system, but this is about those who are vulnerable, those who are looked at differently from those who are caring for them. And so that promotes injustice. Can you tell us a little bit more, Jessica, from even your standpoint, how you have seen bias that has even gone beyond just the African American community.
Yeah, I mean, I think the data that we have, in all of the medical journals, it's just rife within every medical journal you look at, is focused primarily on African American injustice in healthcare, and it's pretty staggering and disturbing to see what we see. But there are other groups and other experiences and other moments where just a bias about somebody, it could be a white man who the healthcare provider doesn't like for whatever reason, and that person is in their extremely vulnerable place. I mean, we had a patient actually a few months ago, and I'm always telling you these things I'm not proud of, but this man was an IV drug user, and he was a white man, and actually one of the residents had a really hard time dealing with him, and it wasn't because of who he was deeply, it was because of these sort of things and these biases that we came to the bedside with. And Betty, this happens very frequently, Betty was the one who really talked to us about this. And in fact, we have some footage about this case that we'll probably put in the film, and really talked about how important it was that we approach this man and get more of his story and try to understand him more. And Betty tells a story about caring for a man who was a white supremacist and for whom people said, don't go in his room. I mean, you should tell this story. It's a great story. Can I tell?
Please do. I need to hear this. Somebody needs to say it. One of you.
Can I tell this? Because I love this story. I love this story. This guy, basically, she was told by everybody, Betty, don't go see this man. Does not like Black people. Do not go in the room. She's like, okay. So she walks towards the room, and outside of the door is the man's son. And he says, Chaplain, please, I wouldn't go in. My father does not, is not very, he's a racist. She's okay. And she goes in. Of course, this is classic Betty. She goes into the room, and the guy is kind of rude to her at first. And she sort of starts probing and asking some questions, and he keeps talking to her. And finally, she basically says, is it okay if I come and see you tomorrow? He says, I don't know. Well, I don't know. She says, is it okay if I give you a hug? And I forgot the most important part, which is at the beginning, when she first walks in, he says, you know what it is about you people? I don't like on TV when I should let you tell the story. You tell the story.
He said, I don't like seeing white men, Black men kissing white women.
Oh.
And I said, I don't much like that either. He said, you don't? I said, no. And so when I got ready to leave, I said, would you like me to come back again? He said, might as well. I said, okay, would you like a hug? He said, sure. I gave him a hug and I kissed him on the cheek. I said, now you've been kissed by a Black woman. And I kept seeing him. We had wonderful, wonderful conversations about race. And when he died, he told his 3 sons that he wanted me to do his service.
Wow.
Yeah.
See, it's just a matter of taking the time to love.
Yeah.
And even when hate is present, love can root out hate, right? We heard Dr. King talk about that on several occasions. And so absolutely awesome story. Thank you both, Betty and Jessica, for sharing that, because that's important for people to hear and to know. I've had a similar account, but I won't go into that because it's not about me tonight. But at another time, we can definitely talk about that. But this is something that happens. We have to understand that racism does exist. We have to understand that bias does exist, and it boils down to how we respond. Do we allow that to continue, or do we seek to, through love and sometimes tough love, break down those barriers? And
you
so
may break down one at a time. It's not a big. You're not going to do big numbers, but that one makes a difference, and you never know who that one. Evidently, he touched his sons because they told him,
Yes.
and so it moves on.
Wow. So here's a question. You said a line in the movie that resonated with me, Betty, that I want you to elaborate on a little bit. You said these words. You said people are talking about them, the patients, as opposed to talking to them. And so can you just talk to us about what do you mean by that? And then how can we change that to more of a positive talking to people as opposed to just talking about them or at them.
Yeah, that happens a lot in the hospital with doctors and patients. I had this woman to say, I'm in the room. She said, I told the doctors, I'm here. I hear what you're saying. Talk to me, and that's pretty common. But there is a different language that I see happens with doctors and African Americans that does not happen with other patients. They dummy down their language as if to say, we're uneducated, we're ignorant, we don't understand. And so I find that doctors use certain words with African Americans, and I will share this one. The doctors asked me and not palliative care doctors, the doctors in the hospital, if I would go in and meet with this patient with them because they couldn't get the patient to understand what they needed the patient to understand. So I go in and I'm sitting there being quiet, listening, and the doctors are saying, we need to wean you off of this medication. And I'm looking at the patient. It's a man, an African-American man. He's getting more and more angry, I can tell. So I said, can we stop the conversation? I said, what are you hearing when they say we need to wean you off of this medication? He said, I'm no effing baby. I don't need to be weaned. So I said, what they're trying to say is they need to bring the medication down as your pain goes down so that you don't become addicted. He said, I don't want to be addicted. You bring my medication down. It was the word wean. And there are words that the doctors use. And I stopped an intern the other day and I said, don't use that language with African Americans. I mean, others may not mind it, but don't go in the room and say, have you pooped yet? That's what we use with babies. And so when you use that language, you're looking at them as if they are not fully able to understand. And just those kinds of things make a big difference.
Wow, you're absolutely right. Jessica, when you set out to begin to make this film, you have a wonderful star in this film, a featured person sitting next to you. So I wouldn't count that as being a challenge, but what has been a challenge for you in creating this film personally?
Oh boy. There's so many.
Being in it as
well. Being in it has been really, was a very big decision. I wasn't at all planning to, for the first several years that we were filming, I wasn't planning to be in the film. And I wanted so badly to show what Betty goes through in working on a staff as one of few African-American people on staff.
For a long time, the only one.
Probably the only one for a long time. What is it like for Betty? What are the obstacles that she faces? And it's important to show that. It's important to show what is going on with people like me. And I couldn't really get any of my colleagues to comfortably talk honestly about the possessing bias, about experiencing bias, about feeling bias. And I realized that it was only going to happen if I was in the film. And so there's my, the second thing. I mean, it's very hard to admit that you have bias. It's easier when Betty admits that she has bias. I mean, we all have bias. I think this concept of not having bias is kind of ridiculous. I mean, it's sort of partly the way the human brain works. I want to acknowledge that and then move forward and say, we feel it. Let's not pretend let's not pretend that we don't have bias. That's ridiculous. Let's move forward past it. So that's only a smattering of the challenges that I am facing in making this film.
I can only imagine. And then one thing that struck me, and I know that it probably struck the audience tonight in looking at it, was seeing Betty in that hospital bed. When you were in that position, Betty, because I'm finding out that a lot of people who are not kind to people who are hospitalized and not empathetic in terms of what they're going through have never been in a hospital bed before. And so I want to know from your standpoint, how did you feel being in the hospital, in that bed, and being vulnerable as it relates to who came into the room, and how you were treated. Now, I know that you're Chaplain Betty, and everybody knows you there. But did you have any concerns about not being treated in a respectful manner?
Yeah, I had a nurse that had to be taken off my service because she would come in, she'd make me nervous, and she would jittery. She'd come in, she'd want to jump early in the morning, and then she wanted to give me a medication that wasn't on my formulary. And that's important for patients to know what they can take and what they can't take. And I said, I don't take that medication. And the doctors haven't. No, she's insisting that I take it. So then she got angry. And then I went 11 hours without pain medicine because she wouldn't come in and give me pain medication. So the next day, I told everybody that I could. And finally, the head people came in and I said, I want her off of I don't want her in my room again. And that happened. But then also with the palliative care team, I had an experience with them that a social worker said, oh, well, we're going to send you to a nursing home. I said, no, you're not. I'm not going to a nursing home. I'm going home. Well, I know you have stairs. And so I said, and I have grandsons, period. And so then we have another member of the palliative care team that told the social worker on the floor, put a sign on Betty's door that she's not allowed to have visitors because she's getting too many visitors. Well, it was COVID. I wasn't getting any visitors. And the social worker who knows me, she opened the door. Do you want a sign on your door saying no visit? I said, no, and tell that person they're the only visitor I've had. So put a sign on the door saying they're not allowed in. I mean, that's the kind of voice I think that we have to have. But I also experienced something really beautiful and taught me something. One young lady on the floor that I don't know her name and I don't know what department she works in because I'm laying there sick. But she comes in and she says, I've heard you sing to patients and you've sang for us and I'd love to sing you a song.
Wow.
And I realized the singing was more important than any conversation anybody else had with me, was just someone coming in and singing a song for me. And so for the staff to know the little things that are important, what difference it makes to a patient who's laying there, just someone coming in and saying, can I fluff your pillow, or are you comfortable? Those kinds of things make a big difference.
I'm listening to you and I'm hearing from you that there was a form of injustice that was displayed when you were not allowed to be a part of the decision-making process, like who comes to visit or, what types of medications you were going to receive. And so when patients are not included in the process, isn't that injustice?
Yes, totally. Yes. And they get it all the time. And we have a lady just said the other day, I don't want to stay here. Please send me home. When are they going to send me home? And she can go, she has a place to go. And they just keep, we've got to get this, we've got to do this, we got to do that. But they're not including her and letting her understand what's happening. So yeah, that's injustice.
Have you ever, and I want to ask this to the both of you, have you ever been involved in a situation where you unknowingly inflicted injustice upon someone in healthcare?
150%. 150. Without a doubt. First of all, it is, we've all agreed and acknowledged that people have biases, and you think, I'm going to acknowledge that, one of the cases we have in the film is about a woman that we met at a funeral. Betty does a lot of funerals of patients of ours. We go out into the community, and this was the sister of one of our patients, and she's a woman with sickle cell disease. And she came up to me to ask me about her sickle cell disease and how, what's the best approach for her right now, and how can she just has so much
pain.
She was in terrible pain, and I don't know where to go. And the truth is, I think back, she was talking about how she feels like a drug addict. You saw that in the trailer. She feels like people think she's a drug addict when she's asking for pain. And the truth is, when I was a resident, we had a kind of a cliche view of what a sickle cell patient asking for Dilaudid was. We just assumed, I'm mortified to tell you this, but it's true. And Betty, sickle cell community organizer in Oakland, is, I mean, obviously doesn't, thank God, have sickle cell herself, but is acutely aware of these biases. And I have participated in those biases. These are things we have to unlearn one at a time. And I hope that by showing them in stories, people will learn and just be moved in a different way to think about the next sickle cell patient in a different way.
And as a chaplain, our biases can remove us from a situation where someone needs to be cared for and loved. And when I first started doing hospice chaplaincy, I went into a nursing home and I'm visiting with this patient and her young niece and nephew, and they were Caucasian and I was comfortable. They were from Berkeley, and I always say Berkeley. And so I felt comfortable. Then an older couple walked in and I looked at the man and my bias said, he's a racist and he don't want me in the room. And he hadn't said a word. So I excused myself and I stepped out of the room. And instead of being there to comfort the whole family, I stepped out and I'm at the desk writing, and he comes out and he says, I want to thank you for being here for my sister-in-law. And he said, my sister died. And I said, I realized it was my bias. And I said, I am so sorry. Would you like a hug? And he cried on my shoulder. And that was when I realized that I have to check my bias when I'm giving care to someone, because it can withdraw care. It can make you step away from what you need to be stepping forward to.
Yeah. And
so what I hear the two of you saying is that all of us have a propensity to be biased in such a way that it can affect someone in a negative way, and we have to be aware of that. And we're not individuals who are not exempt, who are exempt from potentially hurting somebody or mistreating somebody. And so that awareness is something that we need to keep at the forefront. That's what I hear you saying.
Yes.
And if you make a mistake, you can come back the next day and make up for it. You know, it's not like we are perfect people. We do our best, and we all have our good days and we all have our bad days. And some days we will not be behaving in ways or thinking in ways that we're proud of.
And you can go to lunch.
I love it. I love it. I love it.
Well, Jesse, we were in team meeting and something came up.
This was years ago. This was 12 years ago.
And something came up about a patient, and I said it was racist. And Jessica got upset. She jumped up and she said, Betty, not everything is about race. And she stormed out and went up on the floor. And so I was like, okay. So I'm going about my day, and I getting texts, but I didn't look at my phone. So she caught up with me. She said, I've been texting you. I am so sorry. I want us to be friends. And I said, let's go lunch.
A turning point in our relationship, I was saying.
Well, I won't ask who paid for lunch. I won't ask that. But anyway, so and this is for the two of you, and I'm going to ask that Betty goes first, and then Jessica on this question. If you were opening your own healthcare system today, what would you do differently than what is being done now to promote justice within healthcare?
I would start with training. Training would be different. I tell people there is but one race, and that's human. And if we would treat the human race the way we treat the dog race, we love dogs of all colors, all shapes, all sizes, doesn't matter, young, old, they kiss on them and love on them and do all kinds of things for them.
We got cat lovers too, so we don't want to leave them out. That's just okay.
Well, that's the cat family. We're the human family.
Right.
place, and that's human. Everything else is culture. And so culture needs something that we need to learn. We need to learn. And when we start learning about culture, we'll find that we have similarities in each culture that we can identify with one another. We start identifying with one another, we can change some of this injustice. And that's what I do. I'd start out with that kind of training.
That was exactly what I was saying. I really think that's really the answer. And it's a certain type of training. It's not classroom training. It's not teaching people cultural competence, which is a ridiculous concept in the first place.
Yeah.
It's really just about bringing people together. It's about bringing people together with good teachers. It's about having a diverse team so that people can really, I mean, obviously not everybody gets to spend 13 years in a relationship. This is unusual. And that's part of why we're here making this film, because this is an unusual relationship with unusual lessons both ways that I think can be helpful to people who aren't going to have that kind of opportunity. But I do think that if we can figure out how to do training at the bedside with real people, real patients, and show, I mean, I'll tell you, my training was just watching the difference that in my relationship with a patient when I was on my own, with an African-American patient in particular, when I came into the room by myself, and then when I came into the room with Betty. There is something about just making people feel safer, more familiar, and letting this more diverse team do the connecting that I think is really important. So, I mean, there's a lot of things here that I'm throwing in.
Yeah. And now the African-American patients ask me, where's Dr. Jessie? Where's Dr. Jessie?
Well, yeah, I mean, I really, let me tell you something. I can't imagine what it must feel like to come into a system where your people have been abused, neglected, experimented upon for hundreds of years. I mean, just hearing Betty's personal stories about growing up in Kentucky in the 1940s. I'm not supposed to tell your age. Well, whatever. It's all over the treatment, so they're going to know. But, these are stories that are chilling stories. And so you can imagine what people are feeling when they come into this environment where there is just it's sinister in some ways. And so how can I, as a well-meaning person, show that I care? And it's easier for me to show that I care when I go in with Betty, who is more of a trusted person, but I can still show that I care even without Betty.
Well, yeah, because I can tell you one more story about Jessica. The two of us, not too long ago, went into a room, and this young Hispanic woman had been treated unjustly because of her language. And Jessica was on a mission. We went and found people, and we reported it, and it was like, we're on a mission. We're going to make sure this person gets treated right. And that's
and that cruel nurse gets majorly disciplined.
Yes,
sorry.
Yes.
Yeah.
So those are the things that happen when you train, and when you are open to your own biases, when you're willing to grow, and when you're willing to learn. It becomes a more just society.
The two of you, this picture of the two of you is so powerful because the two of you, you said, Jessica, this is, in so many words, an anomaly, right? With the two of you sitting there, the relationship that you have coming from different cultures, different faith traditions, different experiences. And then we also struggle in healthcare with the hierarchical piece of, you have physicians, then you have chaplains, and then you have nurses, and everybody's at different levels. But you see each other as colleagues and as people who are equally capable of caring for individuals. Even though you have a different skill base, you see the two of you as being important assets to a person's care. And so tell me a little bit more about how you depend on each other in healthcare.
You're first.
Okay. Well, I'm not a doctor. So I depend, we are treating the same body. And we need to know that it's not a physical body and a spiritual body. It is one body. And the physical affects the spiritual vice versa. So if I don't know anything about what's going on physically with the patient, it's hard for me to treat them holistically in their spirit. And so I rely on Jessica not only to be the doctor and let me know what's going on, but also I rely on her emotions, her spirituality. Spirituality for me is not religion. It can be, but it's not necessarily. In fact, one patient's spirituality was a Harley. And when I went in the room and I asked, what lifts your spirits? And he said, a Harley. And I said, and he put a big smile on his face, just like you did, and his spirit was lifted. So every time I go in the room, I'd give him the Harley sound.
Well, I mean, I think we have a short, we've worked together for so long that we have a sort of a shorthand. And when we have a new patient that we're going in to see, we have a whole routine. I go to the chart. I'm sitting and looking through the chart.
God, yes.
Betty stands there and I give her the 3-minute synopsis on where we are prognostically and what are the realities, what are the options for this family, what are the options in this situation, and what are all the benefits and potential burdens of each option. And then a lot of times Betty's the one who takes that information into
and all of that's according to the medical. And then we get into the spiritual, and that may not be that at all.
Yeah. No, we really work together very intimately with all of this information, the spiritual and the medical, and putting it together into recommendations and into support and counseling. That is really something that the two of us do much better together than either of us alone.
And Corey, I don't want people to think that it's isolated to healthcare, because relationship, when you realize that you're both human. My family loves Jessica. And when you saw me in the hospital, Jessica's the one that came to my house and took me to the hospital. Her family sees me as a part of their family. So you can't, how it was once integration in schools came along. You went to school together, but you didn't play together. You went to school together, but you didn't swim together, but we work together, but that's not the end of it. But we love each other. We're people. So you become a part of the person's life. You have a birthday party, you get invited. So that's what it's like. You go take a dog, a little dog. You take a dog to a dog park, and all these dogs run around together.
Well, you know what? I have to say this. We say this at weddings, and we're going to get into our Q&A. But I just want to say to the two of you that you are an inspiration to all of us. And to know that this relationship is so powerful. You're an example of what society should look like. And so I have to use these words as we use at a wedding. What God has put together, let no person put asunder. Okay, so I believe God has put you together, and we're all working together for better, safer, well-being, transformation, healing society. I just pulled some words out of that definition that Andy read earlier, but I want everyone to know how important this relationship is and how we need to see more of this across all lines in healthcare. So with that being said, I'm going to ask that Andy come on back in, and we can hear some questions from our great audience that's here at Reimagine tonight. So Andy, got some questions?
Corey, I'm going to take off these spotlights so we can see everybody, okay?
All right.
Here we go. So does anyone have a question for Dr. Zitter, Chaplain Betty, Pastor Corey? Thanks to all of you for putting these wonderful reflections in the chat. But if you wish to ask a question, now is your opportunity. You can raise a hand with your symbol. You can physically raise your hand. We'd love to hear from you. If not, I'm going to pass this to Brad Wolf, Executive Director of Reimagine, to kick us off with a question.
I got questions galore, but I see a question in the chat from Tiffany, Andy. So maybe you want to address that first, and then I
Great. Tiffany, if you don't want to ask your own question, I can read it for you. I'll give you a sec because I think you folks can unmute if you like. Yes, Tiffany, should I read it? Yes, please. Okay.
Yes.
There is a study that showed that empathy scores tend to decline as students progress through medical school. Ugh. Why do you think that is the case, and what could be done to change that?
There are several studies that show that. I think I have an article, a line in my book that I am particularly proud of, which is I went into medical school a human being and I came out a doctor. And I'm sorry to say that our training, I don't know about nursing as much, but I think some of it, unfortunately, is very similar. I think we are trained, we value doing things quickly, we value protocols, we value shortcuts, we value, making things happen efficiently. And the problem with all of that is that you shortcut the human being, and that's what we are trained to do. I'm sad, but true. Yeah.
There was a group of medical students in the hall where they gather when they first come to the hospital, and I passed them 3 days in a row and spoke, and no one said hello. So the third day I stopped and I said, did they tell you that you don't have to speak to people? And they all said, no, and they spoke. We have a lot of new interns on our service. They come on and they have to walk with me at least one day. And now we're getting students who call in and want to walk with the chaplain, want to shadow the chaplain. And I think it makes a difference.
Yep. Yeah.
Okay, we got a question now from Zach. What do each of you have to say about burnout among MDs and chaplains?
You go first.
Oh, wow. We were just talking about burnout when I came in because it has been a really rough couple of weeks. Our census is real high. One chaplain, 3 doctors, and so I have to try and see all of the patients, and that can be burnout. I do a lot of things. So I train the volunteers and I tell them that you got to do something for yourself and you have to have some self-care. For me, I have a large family. I do art. I do a lot of different things. So I rest in another form of work. But I think you have to find what relaxes you and it's important if you love what you do, you take some time, take care of yourself, and get back in there because that's part of who you are and what you love.
Yeah, I would say burnout is a serious problem, and it's even more than burnout is sort of this profound moral distress that I think we experience in our healthcare system because it is so dysfunctional. It is not, we witness the most horrific suffering that is exacerbated by our inadequate systems and our lack of empathy. It's just this vicious cycle of sadness and injustice. And I think that people who come in wanting to help, which is what I would say the majority of people who come into certainly chaplaincy and certainly medicine and nursing, get to a point where we just kind of numb out because there's so much horrific stuff that we see every day and that we cannot fix and we cannot help and we cannot do anything about it. And it's a real problem. I mean, I don't want us to end this on a really depressing, but it's a real problem. We've got to change the systems and we've got to change the way we're caring for people so that we start to have a virtuous cycle and not feel like this. Because yeah,
I call it jaded.
Mm-hmm.
And people get jaded in the hospital because of what they've heard, and they hear it over and over, this patient, that patient, this kind of patient is this way, that kind of patient is that way. And they just go in with that jadedness, And I've been told, oh, don't go into that room because that person is mean, that person is angry, that person is
A drug seeker.
I said, no, I'm going in. And when I came back out, I said, do you know that person's story? And then I try and share that story with them. And I can see the change in their attitude when they hear.
Oh, yeah.
So I think it's just, we just have to keep plugging at it.
And I will say, you know, the optimism here is this. If you do, and that's why we're making this film. If you do find a way and a partner and a sense of a new way to approach it, you really get rewarded. Because what I get from my patient encounters where I do delve into the human connection is so powerful, and it makes me feel so grateful to be in this profession. So I do think there is a way to undo this, but it's going to take some time, and it's going to take some effort, and I hope it's going to take some films. I mean, that's what our whole nonprofit is about, is making films to try to change hearts and minds in a different way.
Betty, you mentioned before about using the arts as a way to soothe, to distract, to heal, you know, from a lot of this frustration or burnout at work. And I went to a training last weekend, and it was so interesting for me to learn that there's this new movement called social prescription or arts on medicine, where the idea is that that medical providers should be dosing creativity and the arts, not only to patients, but to each other. So I know in New York City, the public health system, which is called HHC, Health and Hospitals, they have an artist in residence program, and it's not art therapy for patients. The primary idea is to bring art for art's sake to the staff. And during department meetings, you get to make something.
Wow.
And I just wish more hospitals would do that. Before we move on to other questions, Pastor Corey, is there anything you also want to add to this topic of burnout?
Yes, self-care. You got to know sometimes when to draw the line. You have to know your own limitations. We cannot develop what I call the Messiah complex, right? Where we just keep going thinking that we can save and help everyone. You know, you got to put on your oxygen mask, right, before you can put it on someone else. So we have to be in a position where we are taking the time out to take care of ourselves so that we can get recharged and take care of others. That's something that I did not do for a long time. And now that I have taken on, you know, practices of meditation and things of that nature, I have been able to deal with those hard problems and situations much better. And so we can curb burnout by simply saying to ourselves, enough is enough. I have to step back for a moment and then get back into the game.
Absolutely.
More questions coming in. There was one that I thought was interesting from David, who's trying to broaden this idea of justice beyond the hospital. You know, what can we, like, not all of us work in hospitals. How can one handle these kinds of issues beyond, or do you think there's something very unique about this hospital setting that you're in when you're dealing with issues of justice and injustice?
I mean, I think hospitals are a place where it's sort of the tip of the iceberg. It's the most vulnerable time in most of our lives. And pretty much everyone, regardless of your race, creed, culture, whatever, you're likely to have a period of time where you're going to need to be cared for by people who are healthcare professionals. And I think it is a place to start, because if we can do better in that environment, I think we can do better in a lot of environments. So I do think it's a place to start. It's tip of the iceberg type of situation.
Yeah, and I think it's a place where you get to the core of people.
Yeah.
I mean, all of the facade has kind of left.
Right.
You know, I'm not as pretty as I was. I don't have my makeup on. Although we had one woman who had makeup all over. You know, I can't take care of myself. I have to have some. They're telling me what to do, and so you're vulnerable. That's a place where you can change. Yeah. And hopefully the people caring for you can change, and the people coming in to see you can change. And so it's really a place where things can, as you said, start.
And, I'd like to just add to that, David, and thank you. This is, a great question. When I look at this, I think about the fact that we can tell how sick a society is by how we treat the sick. And I think that's important for us to understand that hospitals represent or is simply a microcosm of a macro issue, right, that we have in society. And so our hospitals help to reveal or amplify the state that we're in by how people are treated in their most vulnerable state. And so if we're treating people like that in their most vulnerable state, that's an indicator that we have some things to change in society that are very unjust when it comes to human beings.
Well, absolutely. Folks, there's a question from Laura, and this is for Chaplain Betty. How much of a patient's story do you put in the chart?
Good question.
Only what can be public, and only what can change or help the clinicians. And so we have a team meeting every morning where we get to talk about the patients. So I can share with the clinicians about things that they need to know to help them care for the patient. But I don't say everything. Yeah, especially things that I feel like are private.
But you'll usually tell us. You'll usually tell our team something.
I tell our team things that they need to know.
Yeah.
I mean to tell them everything.
Yeah.
Okay, we got a question from a granddaughter who's among us. Hope.
Oh,
Is here.
My granddaughter.
Your granddaughter's on this call?
And Hope, you want to ask your question directly to your grandmother?
Where's Hope?
I'm driving home from work. And I can't, I'm trying to do multitasking and all that stuff, but hi.
Hi. What's your question?
My question was, like, how do you feel, do you think that, like, unconscious bias in the healthcare field is more so based off race, or do you feel like it's more about insurance status?
And more about what?
Insurance status.
Oh, I think both of them have a lot to do with it, but I think race and injustice is the highest. Insurance status happens, but it happens around race. So if I have social workers will say to a white male, oh, he's Medi, and he can go anywhere because he's got Medicare and Medi-Cal. And then, this has happened. And then there's a black man who's Medi, and then the social worker will say, oh, well, he can only go to a nursing home with his Medicare, but not Medi-Cal. And I said, but he's Medi. Oh, but the nursing home wants to milk his Medicare dollars. Well, that's not something that we're supposed to help them do, but he's African-American. So they will send, and the thing of it is that the worst nursing homes get the patients that they can milk their Medicare dollars. And that keeps them in business, and it keeps the hospital able to send poor patients out to those nursing homes, where they will send other patients have the same insurance to a better nursing home with Medicare and with hospice. So they'll get hospice and the nursing home, where the African-American person can only get the nursing home. And so it's really sad. Injustice, yes.
Thank you.
You're welcome. Drive safe.
We have time, I think, for one more question, and Brad Wolf has a question. Wait, unmute, Brad.
Thank you so much. First of all, I'm Brad, the Executive Director of Reimagine, and I just want to, first of all, give a big shout out to Andy, who organized this event and invited this incredible panel. I want to give another big shout out to Lily Liu. You see Reimagine collaborator, who I see is extremely active in the chat, engaging everyone. And then a huge thank you as well to my main man, our board chair at Reimagine, Pastor Corey Kennard, who holds it down and is such a visionary and leader. At the end of a long day in Detroit, is jumping on to moderate this incredible panel. And then, of course, to our esteemed featured guests today, Dr. Jessica and Betty. It's so wonderful to meet you and to see this collaboration coming to fruition. This film, which we're all going to see and get behind. I am just so grateful to have you here with us and for all of us to be witness to the wonderful relationship that you have and the trailblazing work that you're doing in the world. There is a question in the chat that I definitely want to make sure is asked, that I think Diane asked, that you please tack on to the end of my question, which was, how can people support you and your vision? I want to make sure you answer that as well with the film, just any kind of plugs, ways that we can get involved in supporting you. Please let us know that. But my personal question for both of you, and this is something that I've really seen at Reimagine, it's been very eye-opening for me. At first, with the last name Wolf, I love the idea of dogs of all varieties coming together in one giant pack. Where we can be together. And that was part of the vision, and it still is part of the vision for this organization. But when we started switching to online experiences, we quickly saw that when we weren't doing events in person in people-specific communities, where we could do events in Black churches or in Latin American community centers, where there were spaces where everyone was meant to come together into one space, maybe more like a hospital, where people from different walks of life come. And in these spaces that we had to reimagine, like these virtual spaces, we said they're for everybody. But when we really listened to the voices of people from different communities, people in the Black community, for example, there was a need to have spaces also that were just for people from those communities. And in some of these cases, what was so powerful is in some of these spaces, as a white person, we were invited in to be allies and just listen and bear witness to a space. And I learned how different, even though I think, we're inviting people of color to be speakers, you know what I mean? And they're also reading the workshop. But when it's actually really led by people from a specific community for that community, the tone really and the way of engaging from community to community is just very different. Yeah. And and I wonder in our healthcare system, how do you think about that for having communities just for, communities for specific backgrounds? And then in a system designed, I don't know, I don't know the exact history of our healthcare system in America, but if I'm assuming maybe it was designed by white people. And so in a system that was designed by white people, is it possible in that kind of system for people of color to really be centered in the way that would actually solve some of these things fundamentally?
Can I tell a quick story to answer that question for 1 second, which has to do with Corey? When Corey and I spoke in 2018, was it? We were speaking together about it for Reimagine. And we were at Sinai.
In New York, right? Yeah.
And we were at Mount Sinai. I've told the story several times because it was shocking to me, actually. We were in New York City. I don't remember why. We were in a big hospital, Mount Sinai. Mm-hmm. And we were on the 10th floor, and we went up to the 10th floor and the elevator doors open, and Corey and I walked out of the elevator, and there was just, 8 paintings of previous people who had run that hospital, and they were all white men, these huge paintings. And I just stood there and I saw it for the first time a little bit more in the way I imagine Corey might see that. And I looked at him, and we didn't say a word. And he says, "Welcome to my life." And it was a moment that resonates with what you were just saying, Brad.
Yeah. Same kind of thing in the hospital when they built the new part for the hospital. And they put up all of these pictures and archives of of when the hospital was old, and they had all of these white nurses. And the hospital now is full of people of all races and all color. And they didn't bring it forward. They just put the history, old pictures. But this one picture of this one nurse is holding a Black baby. And when, and Highland is considered a like public hospital in the area. And whenever there's an elder African-American in the hospital, they always say, I was born here. I was born here. But all of the workers at that time were white nurses. And, you know, where I came from, we only had 2 rooms in the hospital that Black people could be in, only 2 rooms. Wow.
Yes, folks, it is 9:17. For those of you who wish to support this film and this project, I did put a link in the chat for you to follow the film. It is there, so please click on that. We'll also be sending out a follow-up email with information about the film and the same link. So I want to thank Dr. Jessica Zitter, Chaplain Betty Clark, and Pastor Corey Kennard for such a rich conversation tonight. You've given us a lot of food for thought and some momentum to go forward within this series. We've got 2 more coming up. Lily has pasted the link in the chat. We've got next Wednesday, Malkia Devich Cyril, a writer, poet, and grief activist who will lead a workshop in somatic-based practices that acknowledge the harm caused by injustice and that support transformation, healing, and joy. And 2 weeks from now, we've got 2 additional visionaries in healthcare transformation, Nahid Dosani from Toronto and Michael Light from Seattle, who both have been providing palliative care to homeless populations using mobile units. It's going to be a really interesting conversation. We're going to discuss steps at that session for everyone of all professional backgrounds to address inequality and shift mindsets with compassion, service, and justice. Thank you all for coming, and we will see you, I hope, next week. Bye, everybody.